Good afternoon, everyone. I'm Paul Zanata, your webinar host, and I'm the manager of Benetas's Centre for Cultural Diversity in Ageing. Welcome today to our webinar, Palliative Care and Cultural Safety. We've just got a small warm-up activity for you today. We have two questions. For providers, how well do you think you meet the needs of culturally and linguistically diverse older people who are needing palliative care? It looks like that there is, I suppose, a midpoint there of about 3.4 in terms of where providers feel they are in terms of meeting the needs of culturally and linguistically diverse older people in terms of their palliative care. That's good to see that that people feel that they're at least at that sort of satisfactory point, that they're able to be delivering this care, but perhaps aspiring to get towards best practice. And then the second question is, what are some of the main challenges you find in meeting the needs of culturally and linguistically diverse older people needing palliative care? So some of the challenges that appear to come up in the word cloud are about understanding. We're also seeing here poor digital systems, resources and support, different cultural needs, care workers that speak the language of the individuals who use services, access to interpreters, availability of education, language barriers seem to be important here, misunderstanding, a lack of background knowledge, communication. So communication issues seem to be, and background knowledge, organisational policies there as well, restrictions and managing expectations. Our first speakers are from the Aged Care Quality and Safety Commission, Mamatia Khadka and Kristian Wynn. Mamatia Khadka is a registered nurse with clinical experience spanning across acute care, midwifery and aged care since 2011. Mamatia has held a range of leadership roles in aged care and has been working as a clinical advisor in the Chief Clinical Advisory Division's clinical unit with the Aged Care Quality and Safety Commission since 2023. Mamatia has completed a Master of Nursing and a Master of Science in Gerontology and Rehabilitation Studies. Mamatia has a passionate interest in palliative and end-of-life care, specifically in relation to how it applies to older people entering an end-of-life trajectory and how their comfort and dignity can be maintained during this time. Mamatia also has an ardent interest in wound management with a specific focus on the management of chronic, non-healing wounds in older people. Kristian Wynn is the Director of Regulatory Strategy at the Aged Care Quality and Safety Commission. He has spent the last 3 years working in collaboration with the Department of Health, Disability and Ageing on the design and development of the new regulatory framework that commenced on the 1st of November last year with the new Aged Care Act. Before this, Kristian held a range of roles within the Commission, the Australian Army and the private sector.
Just to set the scene, there is no single palliative care obligation under the new Act. You'll see here that we're going to pull out a few relevant ones, starting with the Statement of Rights, and talk quickly about the aged care quality standards. But palliative care and end-of-life care more broadly has a lot of intersections with a lot of different obligations throughout the Act. So we'll just jump into it. Statement of Rights is in section 23 of the Act, and I would highly recommend you all read and become familiar with it. Not only is this an explicit legislative requirement, of course, but it will help you understand our expectations in this space, such as delivering services in a way that values and promotes an older person's spirituality and culture. You'll see there we've pulled out a few of the key rights from the Statement of Rights that talk to an individual's right to have their identity, culture, spirituality and diversity valued and supported, and to have services delivered in a way that is culturally safe, culturally appropriate, trauma aware and healing informed. Those rights and the statement of principles that are also in the Act are things that all service providers, as well as aged care workers, should keep in the front of their mind when delivering funded aged care services. Now, the quality standards are the other ones I want to quickly mention before we go into Mamatia's session. Of course, the quality standards are broadly applicable to all your service delivery, but for our purposes, for these purposes anyway, I want you to think primarily of standards 1 and 5 in particular. Now, standard 1, the individual, makes it clear that your palliative care services need to meet the person where they are, respect their individuality, and enable them to exercise choice and control over the end of their life, including according to their faith and their culture. You'll see, again, I've pulled out a couple of relevant outcomes there from Standard 1. Those are not the only outcomes in Standard 1, and we won't have time today to go through everything. But again, I highly recommend that for those of you that have not yet accessed the department's glossy version, which is the one with all the actions in it as well, that you go and have a read of those in the context of your palliative care service delivery. Just before I hand over, I do want to touch base quickly on Standard 5 as well. Obviously, Standard 5, particularly outcome 5.7, gives you those outcomes that we expect providers to be achieving with their palliative care services, including the preservation of dignity, the management of pain, and access to services that older people need. You'll see there right at the top, palliative care and again, end-of-life care more broadly is to recognise and address the needs, goals and preferences of an older person. And that, again, includes in relation to their culture, their faith, their spirituality more broadly, and their individuality.
Let's have a look at what data says in relation to palliative end-of-life care. 137 palliative end-of-life care complaint issues were received by the Commission, and I'm referring to the Aged Care Quality and Safety Commission as the Commission here, from January to October 2025. This represented 1.3% of all the complaints received by the Commission, which is significant. And just for context, the highest number of complaints received by the Commission relate to medication management, which accounted for around 5% of all the complaints received. Hence, 1.3% of all the complaints in relation to palliative end-of-life care is significant in number. And most of the complaints, 136 out of 137 to be precise, were related to residential aged care setting, and one complaint did not specify any care setting type. Before discussing this slide, I would like to provide a brief overview on how the information that is currently being displayed on the slide is informed. I work in the clinical unit, which is one of the business areas within the Commission's Chief Clinical Advisory Division. One of the functions of the clinical unit is to provide clinical advice on clinical matters referred by business areas across the Commission to support them with regulatory decision-making processes. The clinical unit had provided 80 pieces of clinical advice in relation to palliative care complaint issues between January and October 2025. We analyzed those 80 pieces of clinical advice and identified themes in relation to palliative care delivery. Multiple factors can contribute to an older person not having access to or not being provided with an expected standard of palliative end-of-life care. Following the review of those 80 pieces of clinical advice, the top 3 complaint themes that you can see on the screen, all of which can contribute to an older person not having access to or not being provided with effective palliative end-of-life care. One of the themes that we identified is there is a lack of processes to identify the palliative care needs and preferences of the older person. And you can see the examples underneath each theme. For example, there is lack of processes around undertaking and documenting comprehensive care consultation regarding identifying and addressing older persons' needs, wishes, and preferences, including their cultural, spiritual care needs, values, beliefs, and life experiences. There is delay in identifying palliative care needs of the older person living with life-limiting conditions by utilizing routine screening mechanism, which has been highly emphasized by evidence-based guidelines on palliative end-of-life care. Another thing that we identified is there is a lack of effective clinical oversight in relation to the delivery of palliative and end-of-life care. For example, care plans not being up to date with the care requirements. This also includes care plans not reflecting the older person's cultural, spiritual needs, wishes, preferences, life experiences, and values. Another theme that we identified is inadequate symptom monitoring and management. For example, pain assessment tool being utilized is inappropriate for the older person. Inconsistency in monitoring and managing pain and symptoms. Delay in escalating changes in the older person's clinical condition. Now let's have a look at a case that was referred to us for clinical advice by the complainants. And please note we have altered the personal details of the older person for confidentiality privacy purposes. Let's meet Min. He is 87, male of Vietnamese background, living in a residential aged care setting. He practices Buddhism and his family has been practicing Buddhism for generations. And Buddhism is an important source of comfort, meaning, and spiritual support to him. Min has capacity to make decisions. He speaks limited English and relies on his family to communicate important information. He is living with metastatic cancer and is receiving palliative care. As his clinical condition declined, the family lodged a complaint with the commission stating that the service was not meeting Min's cultural and palliative care needs. Following the complaint, we reviewed the care documentation and also provided the opportunity for the provider to respond to the concerns raised by the family. The family reported the staff often spoke only to Min's family and not directly to Min. The family felt staff did not understand the significance of Buddhist practices or the importance of extended family being present with him. We determined the meals offered to Min did not reflect his cultural preferences, resulting in poor oral intake at a time when comfort and enjoyment of food was highly important to him. Similarly, it was determined the service did not access support services such as interpreter services in a timely manner to identify Min's care needs, wishes, and preferences. The staff heavily relied on Min's family for interpretation and at times even waited for weeks and months for care consultation to occur due to the unavailability of the family. Because Min had difficulty communicating in English, he was less able to express pain, symptoms, and personal wishes. Similarly, Min and his family were not informed of the support services available to him. Overall, we determined the service didn't provide effective palliative end-of-life care to Min. Following the complaint, we met with the provider and discussed the findings. The provider developed a plan of continuous improvement. The provider then met with Min and the family and undertook a comprehensive care consultation and care planning with the support from specialist palliative care team and interpreter. The service also provided educational support to the staff on culturally safe palliative care. They also evaluated the effectiveness of the training and determined the educational sessions have been effective. Currently, the service has been arranging regular interpreter access, sourcing culturally familiar means, and supporting flexible family visits. Similarly, an ongoing review of Min's care needs have been occurring to identify and respond to the changes to Min's care needs, wishes, and preferences in a timely manner. Min and his family have reported improved satisfaction around care delivery. This complaint highlights how culture and language can affect access to and use of palliative care. Similarly, it shows how important it is to work collaboratively with the older person, which gives voice to them, puts them at the center of care, and make care delivery meaningful and effective, which is the overall focus of Aged Care Act 2024. Now let's quickly summarize what we presented. The Statement of Rights ensures that individuals are entitled to receive palliative care in a manner that is culturally safe and respectful. Standard 1 requires providers to understand the cultural values of individuals and to support them to exercise choice and make decisions about their services. Standard 5, Outcome 5.7, outlines the requirements for providers to deliver palliative services and to address the needs, goals, and preferences of individuals during end of life. These are some of the resources that you may wish to access in relation to Aged Care Act, Aged Care Quality Standards, and national palliative care standards.
Thank you so much, Kristian and Mamatia. Now I would like to introduce to you Greg Bourke. Greg is the Support Services and Community Manager at Banksia Palliative Care Service. Greg is a qualified physiotherapist who has worked in public health for 35 years in Australia, the United Kingdom, and the USA. For 2 decades, he has managed multidisciplinary teams delivering targeted community-based services to Aboriginal and Torres Strait Islanders, people experiencing homelessness, people with alcohol and other drug issues, refugees and temporary permit visa holders, and culturally and linguistically diverse groups. Over the past 18 months, Greg has worked at Banksia Palliative Care Service and explored diverse, culturally safe end-of-life care.
I'd like to talk about diversity, and I'd like to talk about the potential of how we deal with diversity in our practical day-to-day work. It's incredibly important. Why does it matter so much? Well, firstly, it matters exactly as Mamatia has pointed out and Kristian's pointed out, is that it's embedded in our standards. But those requirements and those standards are incredibly complex and incredibly intimidating, because they're difficult things to do. I think to a certain degree, we can look at the importance of addressing diversity properly when we look at its absence. An agency that doesn't have the skill and doesn't allow its own staff the capacity to address diversity has the risk of where the client may experience an end of life that is culturally unsafe, devoid of the confidence that they were witnessed and understood by those around them, absent of the feeling that they were respected for who they are, and ultimately a sense, after all that has passed, of not belonging. And I think if we consider that potential outcome, we realize just how incredibly important it is that we try as hard as we can to address diversity. So what do we mean when we talk of diversity? A lot of the time when we talk of diversity, we talk about it in relation to certain marginalized and minority groups. And this is very important. And this is because it is those groups who will be most affected by us not addressing diversity properly. They'll be, and they have been identified by the national standards as the LGBTIQ community, the people who have experienced homelessness, CALD community, people who have been incarcerated, refugees, Aboriginal and Torres Strait Islanders. These communities will experience a poor attention to diversity the most. But it's also important that we realise that our ability to address diversity is not just a bag of tricks we bring out if someone it discloses that they're a member of those groups. It's a set of skills that we bring to all of our client care. And I think it's really crucial that we look at it that way. Actually, it's probably worthwhile just on that slide itself. It's important when we look at addressing all clients that we look at the myriad components to all of our personalities. There's a sense that there is the universal, there is what belongs to the culture, which is age, gender, ethnicity, socioeconomics, and then there's also the individual, the things that are particularly pertaining to us. So how do we properly address diversity? What are some hints in a practical sense? I think the first thing we do is we need to ask ourselves quietly these questions. How is this client, how is this person like all others? And that's the universal. And I think we should celebrate the fact that most of the characteristics of this person will be universal. They will share all the same needs and desires and loves and interests, many of them that we have. And we should never forget that fact. No matter how they may present, no matter what language they speak, that we'll have far more in common with them than not. Secondly is cultural. And the cultural aspect is really important. It comes with enormous complexity, because there is always the risk, I think, of anticipating cultural behaviours, of developing recipes for cultures, of which it's not easy to do, and it's fraught. an expression of indigeneity and of an expression of any culture is multiplicity. It has a multiplicity. It has an enormous range and variation, and we should be really careful of recipes. Individual traits are also key. How is this person like no other? And here we probably need to be aware of trauma-informed care. So what has happened to this person that may have impacted their behaviours, and what sort of variations on our own care and accommodations do we need to make sure that they can achieve their care needs. Trauma-informed care is a very important part of properly addressing diversity. The second thing I think that we can do after asking those questions of ourselves is to appreciate the fact that we are all complex and diverse as well. So as care providers, we're not the neutral from which all diversity is assessed. We also come with our own complexity, our own myriad characteristics. And we need to be very conscious about what the impact we have on clients, what the impact our characterizations are having on characteristics are having on clients. I think as organizations and agencies, we're getting much better at allowing ourselves to reflect on the impact that clients have on us, and frequently how that might be causing our own stress and anxiety. I think we probably have a little bit of time, a little bit of attention that needs to be given to how we're impacting clients. How are our behaviours affecting the way the clients respond and the way their clients receive care? I think this is incredibly important. Thirdly, and most importantly, and Kristian mentioned it briefly in the last presentation, is client-centered or person-centered care. This includes an emphasis on the person, not on their pathology, but that we know each individual client's culture, education, socioeconomic status, gender, expression, beliefs. We know that what is important to our client. We engage with those people most important to the client. We use our knowledge of the above and the client's voice to involve them in the decision-making of their care. We offer the client choice in their care, and those choices are based on our knowledge of what is important to the client. But how do we achieve this? We talk a lot about person-centered care, but what underpins it? Well, I think to begin with, we need to be curious. We need to be curious about the people we're spending time with and we're delivering care with. We need to ask questions. We need to listen. We need to listen to what they say. We need to allow ourselves the time to build a relationship. And it's if we're rushing around from one client to another, there's no way that we can allow the client that time and the capacity to build that relationship. And then finally, in person-centered care, if we've been lucky enough to achieve that relationship, we're lucky enough to have disclosures on elements of their personality and on elements of their culture and their needs, then we all need to be able to document that properly. Frequently, we deal with platforms which are still medical model and don't allow us to be as person-centered as we'd like. We need to develop workarounds for this in our documentation. Clients shouldn't be expected to disclose to everybody. If they bond with someone and they disclose something which is of importance to them and very personal to them, then that should be documented, and all care is informed from then on by that. At the moment, I think it's very difficult to document those things in our platforms, and we need to look at how we can do that better. This is an oldie but a goodie, but the next aspect of this is around equality versus equity. To treat everybody the same way is simply not fair. We know that people have different needs. We know that they may have had traumatic pasts. We know that there are certain cultures and certain groups who have obstacles to their care needs. And to treat everybody the same way is to fundamentally make sure that we're delivering them unfairly. We need to make sure we get equal outcomes, but that doesn't mean the same equals. That doesn't mean equal service intervention. We need flexibility and accommodation. And finally, just touching on families, and this is something that we think a lot about at Banksia, and it's an interesting area. I like this quote: "Families relate to each other as if in a dance, where the steps are infinite and varied, and patterns may exist for generations. In supporting families, we must stay off the dance floor." And I think for the most part, this is completely true. Families have their own syntax, they have their own way of operating, and that has been happening for years. And the boundaries are odd too. I mean, fundamentally we have a contract with a client, and that has the usual sort of healthcare and service provider care consent. But then there's all these orbiting people around them that we don't necessarily have a contract with, and we don't necessarily have the same level of consent, and yet they are big players in this person's end of life. How we deal with that is very important. And perhaps to that point, I think I'd raise only two things. One is that we need to make sure that information that we're getting from the family around the client's needs and wishes are actually the client's needs and wishes, and not just a projection of the family. And then secondly, we need to very carefully and very gently intervene if we feel as if the behaviour of the orbiting carers, whoever they might be, is impacting the dignity and humanity of the person's end of life. And that, of course, is a very, very difficult situation when one has to do that. Can I just touch on two groups which I think it's important that we think about. One is the cultural considerations for Aboriginal and Torres Strait Islander people. There's a number of aspects to this. The first is, of course, to be trauma-informed. We need to understand the history here. We need to understand why a mainstream service provider standing on the doorstep of an Aboriginal person with a badge and a smile is an intimidating thing for that Aboriginal family. We need to understand that history, and we need to be cognizant of it. And we need to make concessions and accommodations in our care to make sure that we're not multiplying that trauma. We need to be aware of we need to be aware of kinship and its flexibility and its extension, and how it varies from other forms of family that we know. And we need to again avoid recipes. We need to make sure that we watch and listen and learn and follow the family and community that we've entered. The second group I just want to touch on before I'm finished is the LGBTIQ+ community. Again, this is a very difficult terrain, frequently because older people of the LGBTIQ+ community are people who may not have had the freedom and liberty that LGBTIQ+ people have today, and even that is limited. But in the youth of the older people of today, there may well have been closeted. There may well have been significant restrictions, and there is a lot of talk about the recloseting of LGBTIQ+ people as they get older and as they re-enter aged care facilities and as they receive care. And it's very, very crucial for us to make sure that we continue to be aware of that and that we anticipate discrimination and we're wary of it whenever it comes. Finally, I just want to touch on these 5 points. Firstly, and this is as in properly addressing diversity. Firstly is training, is making sure that we have training on trauma-informed care, on intersectionality, on various cultural groups, as listening and communication. We just continue to train, and but we also are very aware and conscious of recipes, and very aware of and conscious of anticipating cultural behaviours, which can be just as impactful and just as prescriptive and inhibiting as if we knew nothing. So we need to be aware of that, but we always need to continue to keep training. Data is really important. We need to collect good data on our clients and then compare them to the clients of the citizens of our region. Do our clients reflect our region? And if not, why not? And investigate that. Investigate whether there's any obstacles there to the clients accessing our care, whether there's word out that perhaps we're not providing culturally safe care. Just be conscious of that all the time. Our clients should represent the community that we're supposed to support. In that case, I jump forward to community engagement. Where when we find that they don't, we need to relate to the community. We need to engage with the community, particularly upstream organisations and referral organisations, but also social networks and community groups, to make sure that we learn as much as possible about what good end of life is for various groups, and that we put our name out there, our brand out there, that we're open to learn and we're open to safe cultural practice. Next, we need feedback. We need to constantly be getting feedback from all of our clients, but particularly those marginalised and minority groups. How did we go? How did it go for you? Were we safe? Did we respect you? Learn as much as we possibly can, and that's the best training that we can possibly get. And then finally is staffing. Just making sure that our staff represent the community that we're trying to serve as broadly as possible.
That was a fantastic presentation, and I appreciate the reminder that you also gave us about the intersectionality in respect of diversity. A really important and salient point. And now, finally, introducing Terri Soumilas, our last presenter today. Terri is the community, delivers community engagement for Mercy Palliative Care. Terri Soumilas has a long history of working with multicultural and multi-faith communities, along with a strong commitment to inclusion and social justice. She brings extensive experience in community development, advocacy, and partnership building, with a particular focus on amplifying the voices of marginalised and underrepresented communities. Terri's passionate about creating culturally safe, responsive services and supporting communities and their families through inclusive, community-led approaches. Her work is informed by a deep appreciation of how culture, identity, and structural barriers interact, and the importance of collaboration across sectors to achieve meaningful and lasting social change.
I'm really feeling very pleased and privileged to being here in this room and hearing the speakers beforehand. It's great to be aligned with them and feeling like I'm part of the picture here. I am talking about walking beside families and communities and reflections of palliative care in multi-faith communities. So it's a narrative that I'm presenting today. It's my experience. I want to share my reflections. It's about my reflections, and particularly with multicultural and multi-faith communities. These experiences are now shaping the way I understand how care and dignity and connection with at the end of life. What I offer is not theory, not just theory. It's about lived experience, walking besides families, communities, and definitely the service provider, the staff here at Mercy in terms of the care they deliver. The biggest thing I think I really find when we're talking about palliative care, we are in a really sensitive, profound human moments, in the sense that we're caring for people at their most vulnerable. And the care is not clinical, not just clinical, and we need to remember that. It's about the relational, cultural, and deeply personal. The work asks for humanity, patience, and listening that goes far beyond language. It's the way we're listening. And I suppose just what I'm trying to do is a thread to all my reflections. And today, to begin with, every day is a reminder that care is shaped as much by our culture as it is by our illnesses. So when worlds meet, different understanding of what care is. Not all communities share the same concept of comfort, focused care, or advanced planning. So in some cultures, speaking about death is a taboo, and in other cultures, decisions are made collectively. And these definitely challenge Western models of health, where we provide prioritize autonomy and early planning, and that can often clash with some cultural norms, and that is where the collective decision making and cultural perceptions or cultural connections or commitments are different to that sort of model of Western health. So within that, a single conversation can reveal how different families understand what it means to care for people at the end of life. So what we need to do is slow down and listen differently, and to recognise care is not clinical and it is relational. I've learnt that humility, and patience are not optional. They're a foundation for trust, and often the most important things communicated in these moments are often not even spoken. So systems, power, and the weight of the people carry. Many families face grief layered with migration, stress, trauma. I suppose that it's a lot what Greg was talking about, the different layers of grief that come, things like migration, stress, trauma, and intergenerational expectations that people caring for their elders in a different setting, in a different country is quite different. It can often clash or just are difficult to manage. And definitely for people from different migration stories and histories, health systems can often feel overwhelming and fragmented or culturally unsafe. Outreach, and this is where I really believe that outreach and advocacy are not extras, they are essential. Meeting people where they feel safe builds trust and access. So many families we support are carrying more than illnesses, and they're navigating all these language as well as things I just mentioned, but language barriers and barriers and serious diagnosis on top of a health system that can be so overwhelming at times. This work is emotionally demanding, but it's also deeply meaningful. I think we really need to keep reminding ourselves the work we are doing is very meaningful to not only the person, the patient, but the communities around the person. These moments have challenged my own assumptions of what good planning looks like. They have pushed me to reflect on my own cultural lens, and that's why this whole thing I'm trying to present, to talk about, is my reflection and what I've learned. Shared values and create a foundation for culturally safe practices. Every family teaches something new and quite different, so we're all unique. Is the point? We're all unique in many ways. People honour their own. As the saying that my learning has come from working within Mercy, not only Mercy Palliative Care, where I've worked with physios, nurses, doctors, walking along. So they are very committed to what they're doing, and learning how important this phase of people's lives are, or our communities are. I've also been really lucky to meet and be people in different services that come in at this time, and organisations. Palliative Care Victoria has an amazing role to play in this, and helping all our services to reach our optimum and what our community needs. This, and again with Mercy Palliative Care, mission commit to excellence, care for all faiths and identities, shared values to create a foundation of culturally safe practices. And it's the biggest thing I'm making is this thing about it is a collective process that we need to build our organisation and the work that we do. Dignity. Love that word. I think dignity goes across a lot of things, and that needs to be the undercurrent of how we approach our work. And when I talk about my position as community engagement, we recognise the importance of having to build those relations way before they actually need palliative care, and with those communities that face a lot of barriers. And that's why we need community engagement that comes and connecting before they come to us. So that we build the trust with our communities for when they need us the most and understand what we need. So dignity, palliative care is not only about dying well, it's about being seen, heard and honoured. So in the end, the work we are walking alongside people in a way that honours their culture, their faith and their story.
That was absolutely fantastic and really, really profound and thought-provoking. I'm also introducing now another person to today's panel, Mary Tatham. Mary's the clinical advisor in the clinical unit of the Aged Care Quality and Safety Commission, and Mary joins Mamatia and Kristian as a member of the panel representing the Commission today. There are many things that came up and struck me today as I was listening to these wonderful presentations. And I think one of the first questions I'd like to ask is, what have you found is the best approach to working with families that don't want to discuss palliative care or death? And there was a really good point that Terri made about the fact that different cultures, different individuals will have different feelings about death and talking about death. And clearly an aged care, a team in a community-based setting or in a residential aged care home setting may be wanting to discuss with the person, with the family, these issues around palliative care and death, but people don't seem to be ready or don't want to have that conversation. How do we deal with that? Maybe I could ask Greg as a starting point, particularly given that Banksia Palliative Care, I assume, does some really good inreach into people's homes or into residential aged care settings.
Yeah, we do, Paul, and it's absolutely a pivotal question, because frequently people end up on palliative care when they're not exactly sure they're ready for that, and if they're not ready, sometimes certainly the family aren't ready. Because they've had often less time to reconcile themselves to this changed context. What do we do? Well, firstly, we allow time. We pick up very early on that somebody may not be in a position where they want to talk candidly about their situation. And this is what I said earlier about potentially using documentation as much as possible to foster person-centered care. Is there's a section on our platform, our documentation platform, which is around insight to illness, and we capture where the client is and the family, and also where the family is in regards to their palliative diagnosis, and then we track that, and we make that a point of honor that we hopefully increase that insight as we go. And we do that carefully and we do that gently, but that is something that we like to address, because we feel as if to push it away is not in anyone's interest. We've also equally brought in a document called the care plan discussion that we have, which is something that we bring forward to the family when we first meet them. And that has some quite pointed questions, but where we feel that's not relevant, we don't immediately address those, but we do leave that conversation piece with them, and then we say, hey, when you've got time as a family, maybe you start to go through these, and then we come back to that conversation over the following months. Have you had a chance to discuss that? Have you looked at those questions, et cetera, et cetera? So we're not throwing it in their face, but it is there, and I don't think it's in our position to ignore it completely.
A position like mine has been created a community engagement. So it's even before they get to the service that relationship needs to build. So those sort of, when I first came here, they had the volunteers would do shopping centre tables and hand out information. And I really thought, shopping centre talking about palliative care. But it is a really good way, because, everyone goes shopping. Not everyone goes to the library. Not everyone goes to council buildings or community groups or social groups, but everyone goes to shopping. But it is that incidental connection that we can make, hand out the pamphlet. People are amazing. They stop and they do talk. So they know It's in their radar. They're starting, oh, there's a service that does that. Oh, well, that's interesting. Oh, I wouldn't want to do the work. I mean, try telling people what you do at a party. Oh, my God, everyone stops and walks away. But those conversations are really important. And it goes across cultural groups. It's a bit harder. There's a lot more barriers that we need to address when we're talking about different cultures, different experiences and stuff. But the conversations need to happen before people need the service and stuff. That's the biggest point that so when they do make decisions, they make informed, timely decisions.
That engagement and developing that trust before that a person's health deteriorates to such that they're looking at palliative care, and that can still occur within that residential aged care facility where you have in most times you do have some time to develop relationships and trust with the family and the older person before their health starts to decline. And it is difficult, like Greg said, it's a very difficult conversation when you're dealing with that sort of entry into residential aged care and you're asked the question about palliative and end of life planning. It's can be very overwhelming for staff as well. But there is that opportunity to develop that trust and relationship before it gets to that stage. That really resonated with me, Terri, what you said there.
A couple of aspects to that engagement piece and that trust building piece. Have you seen examples either in a community-based aged care service or a residential aged care home where either one or more members of the care team have actually gone out and engaged with those important cultural or faith groups that might provide support to the person in the community or resident? And I was particularly thinking and reflecting upon Mamatia's case study about Min. And Min had not been connected with a Buddhist monk. And that was material within the complaint that had been made by the family and by Min to the Aged Care Quality and Safety Commission. Have you seen examples, good examples of when providers have actually have a system in place for actually upreaching or going back into the community to ensure that those resources are actually connected to the person that they're looking after?
So talking about Min's care needs and the case that we presented, Min requested regular visits from monk, and that wasn't considered. But after the complaint was raised with the commission, what happened is the service accessed support services from hospital, from specialist palliative care team, and from their community as well, from their community monastery as well. They contacted them, and that's how they were able to organize regular visits from monk. That's a great example of this can happen if an older person has cultural care needs, and if they want some other personnel such as monks or priests to address their cultural care needs. I think that is possible by accessing support services. Again, as mentioned in Min's context, it was hospital. They access support from hospital, from specialist palliative care team, and their community monastery. So that's how it was possible. So yes, it is possible, definitely.
I suppose it really suggests that for members of an aged care team in a service, they need to be equally comfortable that it is extremely legitimate for them to contact faith leaders and members of faith communities or other cultural organisations, just as much as they might contact an allied health professional for an allied health referral, or, as you say, a specialist medical service on behalf of the person. They should see this as an ordinary part of their role.
And it is important to consider these preferences, wishes, and needs from the get-go. I think that makes it more accessible and easier for aged care providers to connect to those faith leaders. So even before the older person is admitted, when there is pre-admission interviews or screening, if wishes and preferences and needs like these is identified in a timely manner, I think it provides time for the provider to access those services and makes it easier for them.
How do you uphold a resident's dignity and right to choose when their expressed wishes conflict with their family's view of what is best? And what approaches help you to respectfully support both perspectives without dismissing either? So this is like this is like when the family and the individual have different perspectives, they're strongly held, and it's an emotional time. How do providers manage to stand in the middle and respect and uphold the views of everyone, and understanding, I think the term used was before, the contract that we have in relation to care?
Yes, definitely. Navigating different preferences for palliative care can be very common and can be very challenging as well. However, if this is the issue, the key is to shift the focus from what the family wants to what the older person wants, and ensuring that the older person's dignity remains central while validating the family's fear, grief, and hesitation. And in this instant, it's important to make the older person and the family aware that the older person is at the center of the care and they have the right to make decisions regarding their health. And it's also important to provide safe space for the older person to make decisions without hesitation and fear. However, also listening to families' wishes and preferences is important, but making sure that it is the right of the older person to make decisions regarding their health matters. It's paramount. It's very important.
I think that it was an important point that Robert Fitzgerald, who is now a commissioner with the Human Rights Commission, made late last year in the release of his report in relation to older people and healthcare, where he made the point in his report that older people sometimes have their families taking over, not in a malignant way, but in a benign way, but not realizing that they're removing the agency of the older person. And in fact, that becomes more pronounced when there is, a language issue where perhaps an older person doesn't, have a high level of English language proficiency, and they're even relying upon their family members in relation to interpreting. So, yes, a reminder that we've always got to come back to the older person. One of the things I'm really interested in is we talk a lot about preferences, and I'm just wondering, to put a really, I suppose, important blue skies, I suppose, perspective on this is, should we be asking the question when we seek people's preferences, should we have in the back of our mind that in relation to palliative care, there's this sort of existential question about what is possible? So what are the true wishes of the person, not just in a sense of saying, oh, we're providing, culturally safe care because we're doing X, Y, and Z, and we make sure we've got an interpreter. But can you describe situations or examples? Greg, you may have seen this particularly in the community setting. Any of you from the Commission or Terri may have also seen that those more extraordinary steps that an aged care provider may have taken to really work with the person to ensure that those sort of deeply existential or ontological type experiences were able to be seen through for the person. Does anyone have a really good example of what that looked like?
We have quite a number of those type of experiences, and frequently they emerge from our staff who have the good fortune and the privilege to spend more time with the clients. So our massage therapists and our physiotherapists who's while exercise is being done, sort of sit there and spend time, and they're quiet with somebody. And probably the most moving moment, and perhaps because it was captured on film, but one of the most moving moments was a couple who had perhaps become a little bit separated over the stresses of end of life, and they spoke of their glory days when they used to dance and they used to love to dance. And that was kind of their thing. That's how they expressed each other, their love for each other. And our physio said, well, okay, that's what we're going to do. And they worked on their lower body, worked on the gentleman's lower body strength and his core, and he improved his balance. And they put on their, and then after a month and a half, they put on their favorite song, and the two of them danced together, and there was a really moving moment. It was and captured on film. It was. I hope that's what you're looking at, but it was something which was really profoundly moving for everybody.
The uniqueness of a palliative care model is that it's surrounded by different services or different, professions, the physio and the occupational therapist, the social worker, like you said, Greg, masseur. It enables people to, they might not go and do that bungee jump, but at least the biggest thing I hear about people in that time of their lives is it's a time to just talk and remember and support. And that's what a unique sort of the palliative care model is about. So in terms of what you're saying even beforehand about if a patient's saying one thing and the family's saying another, if we've had, the palliative care model would see that coming, to be honest, that the nurses have gone in and stuff and the social workers have been there, they would see that and develop that relationship. They would see that sort of division on it coming, it doesn't just pop up. And that's what we've got. And this is the sort of model that we need to keep having, is that sort of diversity that comes in. So people can't, always wanted to bungee jump, but they physically can't. But they can talk about it, about their movies and stuff, or tell their stories and why they never got around to it. Maybe it doesn't necessarily they don't have to actually do it,
I think that central thesis is that that I heard today in the presentations, particularly from yourself, Greg and Terri, is that there does need to be time given to people, that we need to listen to the older person. And this is a universal thing that we might consider. How do we support our teams who are often very rushed and feeling busy and off their feet, and also recognizing that staff themselves have their own cultures and their own personal beliefs about death and dying, their own experiences as well, which may be accommodated by, some degree of trauma. How do we, and I'm putting this to everyone, what does good support for aged care teams look like in a palliative care context?
I've seen some various examples of this, and I think, with the very multicultural workforce that we have, provides a lot of opportunity to provide that individual care for different cultures, but it also does have some barriers where staff's culture might be different to that of what they're expected to provide. The example that I can think of is an old digger, war veteran who was the only survivor in his unit, and who lived with great suffering because he didn't believe he should still be alive. Now, he was welcoming his end of life. It was a completely different scenario than usual, and staff really battled with that. And really needed support because he was a very sad man, and it was just his approach to death and dying was so different to, I guess, what they were used to seeing in a residential aged care facility, and staff really battled with that emotionally. So I think it's just particularly your odd floor staff who are supervising teams on a daily basis. It's just to know your staff and listen to your staff as well, and respect where there may be staff battling, and provide that support, and maybe alternative shift arrangements. And that was a very complex case for that gentleman, who was a lovely man. That's the one that always comes to my mind.
I think it's a really good example, and I think tells the story that we do really have to be mindful of where our staff are at, and they do, I suppose, really hard work every day, and this is something that creates a further layer. Thank you, everyone, and we look forward to seeing you again soon in the Centre for Cultural Diversity in Ageing's webinar series. Have a great rest of your day.